Good morning, everyone, and welcome to the Rocky Mountain MS Center Education Summit. At the conclusion of the presentations, there will be a 15-minute question and answer session where you can submit questions as they relate to the presentations from our physicians. You'll find note cards inside your program folder, and we have volunteers who will come around the room and pick them up throughout the morning, so please look for a volunteer to submit your questions. I'd also like to call your attention to one other item in your folder, the evaluation form. Please take a few minutes to fill it out before you leave today. We're constantly looking to make these events engaging, informative, and useful to you, and your feedback is absolutely essential in making sure that happens. Now I'd like to introduce our first speaker, Dr. Augusto Miravalle, who will present on biology and genetics of MS.
Thank you. Thank you, and thank you, Gina, on behalf of the Rocky Mountain MS Center for the invitation. It's a pleasure and an honor being here. Can you hear me in the back? Okay, and thank you all for being here. Speak up. Okay, that's better. So thank you for being here in this beautiful Saturday morning. We hope that this program is helpful for you, and we can probably update you on many important aspects of multiple sclerosis. So let me start the presentation with some information and data numbers on multiple sclerosis. So as you can see in this slide, MS is a common disease, and we will talk a little bit more about how geography affects the incidence and prevalence of MS. But regardless of the location, MS is common. And the incidence of MS, meaning the new cases per year, continues to grow. That growth seems to be more pronounced in females, in women, but regardless of the gender and geography, the incidence continue to grow. So currently, we estimate that over 500,000 Americans live with MS. That constitutes a significant number when you look at the incidence in the world. 2.3 million people in the world lives with multiple sclerosis. Colorado happens to have a high incidence and prevalence both of MS, and the reason for that is still unclear. However, as we will discuss in future slides, possibly factors in the environment as well as genetic factors may play a role. So as we know, if we don't impact on the disease, unfortunately the disease will continue to cause disability in patients, and most patients that do not receive treatment may require assistive devices for ambulation, cane or wheelchair, anywhere from 10 to 15 years from onset. If we don't impact on the disease, it could affect the life expectancy. However, with recent information from clinical trials, we know that when patients are receiving the right medication and the right interventions, life expectancy is the same as healthy controls. MS is also very costly. It is estimated that the total cost to the US economy is $9.4 billion per year. And this is related to direct cost of medications and care, as well as the indirect cost of disability in a population that is young. And related to that, MS is the leading cause of disability in young women and the second leading cause of disability in young men in the US. So what causes MS? We still don't know, but it's very clear that it's not one factor. It's a combination of multiple factors. And in this slide, it's tried to represent the three areas, the three buckets that we know have an interplay in increasing the risk of MS. One is environmental factors, genetic factors, and possibly factors related to the immune system that the patients have acquired through life. So in the slides, you're going to notice that between brackets, you will see AAN 2015, and that stands for American Academy of Neurology meeting. Every year, we have a major meeting. All neurologists go to this meeting. This year was a record number. Over 12,000 neurologists came to the meeting in Washington, D.C. in April. And all the information that was presented there, I tried to condense into these slides. So everywhere you see AAN 2015, that's a brand new, fresh information from this meeting. So some of that, probably you're gonna be the first group of patients that have access to this information. So what do we know about diet and multiple sclerosis? So as you can read in the slides, it seems like there are certain factors that are directly related to nutrients that we receive in the diet that has been seen to be low in patients with MS, possibly related to the cause, possibly an effect, we don't know. But among those, folate, magnesium, vitamin E, those are the ones that has been described. It is unclear if you supplement with these whether there are any impact on the outcomes. However, there is no known risk of supplementation with these factors. So up until we get more evidence, it might be a good idea to actually try to supplement these factors with a multivitamin. Another important piece of information that was discussed in the last AAN meeting was the fact that Mediterranean diets may impact in brain atrophy rates. And this is not only in MS, this is also true for Alzheimer's, for Parkinson's disease, and any other neurodegenerative disorders. What is a Mediterranean diet? Well, that's the diet that has high level of vegetables, fruits, grains, and fish. In addition to that, in MS patients, it seems like diet is a factor that will significantly improve the distribution of adipose tissue or fat, and particularly fat that has been shown to have a pro-inflammatory component to MS. So we knew from previous studies that people with MS who are also obese or overweight, they do worse. And it's not just because they have more difficulties with ambulation and actually the care, but also because there might be an effect on adipose tissue and fat into the way the immune system will respond, creating a pro-inflammatory environment. In addition to that, if you intervene with a high diet with high content of, for example, fish and vegetables and fruit, and low trans fats and saturated foods, patients actually do better, and they have decreased levels of fatigue. So all of this was recently presented and is very important, and those are things that you can actually start doing today. So what about culture and demographics and the risk of multiple sclerosis? So we know that the risk among white non-Hispanic individuals is about 1 in 400 in the lifetime, and this is considering all geographies. They tend to be a lower risk among certain demographics, and particularly among Hispanics and Black and Asian populations. However, in people from different cultures, particularly Hispanics, the outcomes tend to be worse. And possibly that is related to a predisposition that certain cultures and certain genetic factors have in cultures to create lesions in different areas of the brain and the spinal cord. The concordant rate of MS is a 5-fold higher in monozygotic twins. Having a sibling with multiple sclerosis increases the risk of MS from 20 to 40-fold. And they recently described 12 new genes that are related to the familiar forms of multiple sclerosis. So as you know, up to 10% of MS patients have a first-degree relative with multiple sclerosis. So a common question that I usually get in the clinic is a newly diagnosed patient with MS. They want to know what will be the risk of the disease in their offsprings, in their kids. And the estimated risk is double to population who do not have a first-degree relative with multiple sclerosis, and depending on the area, it could be as high as 3% chance. So as I mentioned before, the incidence continue to grow, and as you can see, this is an example from a study done in Buenos Aires, Argentina, which it was thought to have a low incidence of MS. However, due to migration factors and other factors, the incidence is growing from 1 in 100,000 to 4.9 in 100,000 in that period of time. So it's a rapidly growing incidence. So what about viruses and MS? And since Charcot described this disease in the 1800s, viruses has been considered to be a factor causing MS. And the most common or commonly implicated virus is Epstein-Barr virus, the virus that causes mononucleosis infecciosa, or mono. And the reason for that is because the Epstein-Barr shared proteins in the virus that are very similar to myelin. So the thought is that when patients get exposed to this virus, the immune system is going to respond to that to try to fight the infection. And our immune system is very smart. And they have cells that are called memory cells. We have memory T cells, we have memory B cells. And those cells are there to help us in case we get re-exposed to the same agent in the future. We can mount an immune response faster. The problem with that is that if those memory cells get confused and they respond to things that are very similar yet not the same, you can mount an autoimmune response. And this is a case that is called molecular mimicry, in which our immune cells, our memory cells, are getting confused. And instead of responding to an Epstein-Barr virus or any other agent, they are responding to our own proteins. In the case of MS, to proteins present in the myelin, causing demyelination. So the story with Epstein-Barr virus is very interesting. This was the largest study done in the US looking at patients with MS at the VA system. And they follow patients over time. And they look at those patients who were negative for Epstein-Barr virus. So they've never been exposed to the virus. And they follow them over time, and they notice that the moment the patients were exposed, soldiers were exposed to the virus, there was a temporal relationship between the first infection and the development of multiple sclerosis, suggesting that the virus might play a role in the risk of MS. It seems like not only the presence of the virus causes a risk, but also when people is exposed to the virus. And this has to do with this common sense of the sooner your immune system is challenged with infections early on in life, the better you can control autoimmune responses or dysfunctional responses. So let me tell you that what my grandmother used to say when I was a kid and I was playing with dirt and I was probably not washing my hands before going to dinner, my grandma used to say, well, at least he's mounting a good immune response. And probably she was right, because the truth is that if our immune system is too protected early on in life, all those mechanisms that we have in place to abort autoimmune responses or dysfunctional responses are not being used. And if all of a sudden we are exposed to those viruses, those bacteria later in life, those mechanisms may not be as healthy. And that's why the study looked at what happened when people get exposed to Epstein-Barr virus early on in life. Well, that risk of MS disappears. However, if you're exposed to Epstein-Barr virus later on in life, after your 20s, the risk of MS increase. So it's not just the virus, but it's also when your immune system is exposed to the virus. And in this slide, you see that there is a direct link between when people is exposed to certain viruses and when they develop multiple sclerosis. So keeping that concept in mind, which is called the hygiene hypothesis, meaning if countries with poor sanitation, meaning that kids will have more incidence of infections and higher rates of infections early on, you see that there is a decreased number of autoimmune disorders, MS being one, but also it's true for lupus and asthma. These studies, again, were presented last April 2015, looked at what happened with parasites and the risk of MS. And as you can imagine, populations that have high incidence of parasitic infections, they have lower incidence of multiple sclerosis. And in patients with MS, who are also co-infected with parasites, their disease process tends to be milder than people without the parasitic infections. So please, don't leave the room and try to get a parasite, because that's still not a treatment for MS. However, there is a clinical trial looking at a helminth, which is one form of parasite, and try to see whether if we vaccinate people with this non-infectious form of parasite, the course of MS might be milder. And the thought behind that is that as you challenge the immune system through a different route, in this case through parasites, you might be modulating those immune responses towards an anti-inflammatory instead of a pro-inflammatory response. What about genes? And I mentioned that there were recently 12 new genes reported in the familial form of MS. But in the non-familiar form of MS, there are over 110 genes that has been identified. Virtually all of those genes have to do with our immune responses. It's how well our immune system is able to recognize foreign antigens versus our own antigens. And if there is any mismatch between the two, that has to do with the risk of autoimmune responses. There's one exception to those genes that has to do with the way we metabolize vitamin D. And it seems like patients with MS have a higher likelihood of have vitamin D deficiency. And that brings us to the next slide, which has to do with race. That is true. The vitamin deficiency story is true in Caucasians, in whites, but it's not true in Latinos and blacks. So it has to do probably with some sort of genetic component as well. We already talked about this, but what I want to emphasize is that even though the risk of MS is lower in certain ethnicities, the actual prognosis may be worse. And not only due to maybe decreased access to healthcare, but also it has to do with some sort of anatomical variation. And Latinos, and particularly Amerindians, tend to have more of an opticospinal presentation, meaning that their MS tends to affect the eyes and the spinal cord, a pattern that is very similar to a disease called neuromyelitis optica. And probably that has to do with some sort of genetic predisposition as well. And this is just to show you a very interesting theory behind that, that when you look at MS in Japan or in Asian countries and MS in the native populations of Americans throughout the continent, it's very similar. And as you can also see, Native Americans throughout the continent, they have some sort of facial Asian features. And this might have to do with the migration patterns early on in the population and how the risk, it might be related to, again, genes and where these populations are coming from. So we talked a little bit about geography and the risk of MS. We traditionally learned that there is a latitudinal effect with multiple sclerosis in the world, with certain areas that have a higher incidence of MS, the US being one of those, Norway, Sweden, Denmark, and areas that have a low incidence of MS, like Central America, Africa, and some places in South America. However, as we all know, people is moving constantly, and particularly now. And when you put together the risk of MS based on where people grew up, again, places with poor sanitation, higher risk of infections, lower risk of autoimmune disorders, usually those patients in third world countries tend to migrate early on in life looking for a better education and financial situation. So as they migrate, they're going to mix the risk of MS when they go north, and particularly to areas in first world countries. Conversely, people who grew up in first world countries with better sanitation and hence higher risk of autoimmune disorders tend to move later on in life after they accomplish better financial status, looking for better quality of life. So they tend to move south. So all of these factors, the push and the pull factors that is making people move, is changing the landscape of MS in the world. So let's go to vitamin D. As you are all aware, there is a risk of higher risk of MS in populations with low vitamin D, and also in people with MS. If they are deficient in vitamin D, there is an associated worse prognosis. So let me poll the audience here for a minute and raise your hand if you're taking vitamin D. Good, this is excellent. Okay, and actually I'm taking 2 vitamin D because the more we learn about vitamin D, the more we realize that usually it cannot hurt unless it goes to toxic levels and might be having effects not on the immune system but other factors as well. So what we recommend currently is levels between 50 and 70 nanograms per deciliter of vitamin D3. We measure that in the lab as a vitamin D3. We usually do that every 6 months or so. Most patients in Colorado will require anywhere from 5,000 to 10,000 units daily to accomplish those levels. So as you can imagine, the map of the world when you look at vitamin D deficiency is virtually identical to the map of the world when you look at higher incidence of MS. So again, places with low vitamin D in patients have a higher incidence of multiple sclerosis. So what is the relationship between vitamin D and the immune system? Many. But basically, to summarize this slide, it's going to promote a differentiation of immune cells, again, from a pro-inflammatory behavior to an anti-inflammatory behavior, promoting decreased inflammation and hopefully modulating those abnormal immune responses. Let's move on to salt. And as you can imagine, salt is bad for MS. And this has to do, again, with animal studies and now replicated in humans as well. Populations with high sodium diet in their diet have a higher risk of MS, and patients with MS who take more than 2 grams per day of salt, they have worse prognosis. So how much is 2 grams a day 2 grams of salt per day? Well, that's basically not too much. If you look at the sodium content in processed foods that we eat, hopefully not every day, but we usually eat, that already almost matched those 2 grams a day. So virtually, by eating processed foods, you're already at that level. So if you have the choice to cook and prepare your own foods, do that, and please don't add any salt to your diet. And this is, again, the recommendations is not to exceed 2 grams per day of salt, but the average American is, the level of sodium in their diet is anywhere from 4 to 4.8 grams a day. So that's something you can start watching. Well, as you can imagine, cigarette is also bad for MS. And I don't need to tell you that if you're a smoker, please try to do anything you can to stop smoking. There are many strategies that we can help you to accomplish that. But cigarette smoking in MS it's a bad combination. Patients with MS who smoke, they have a 10-fold higher chances of poor prognosis than people who do not smoke. Conversely, it seems like coffee might be good for MS, and this is something that was recently presented at the AAN. So more to come here. We can still recommend that, but there is a trend to see that, as you can read in these studies, people who drink at least 4 cups of coffee a day, they have a lower risk of developing MS. It is unclear if you have MS already what happened with coffee, and as you can imagine, too much caffeine might impact on your sleep cycle, and then if you don't sleep well, you may have more fatigue the next day, and if you try to drink coffee, you create this vicious cycle that is not healthy. So be careful of how you take this information, but it seems like it is a positive trend towards drinking coffee and a lower risk of multiple sclerosis. So this concludes the first half of the presentation, which has to do with, again, this interplay between geography, environmental factors, and viruses, and so on and so forth in MS. The second half, I want to present to you a new model of the disease that was presented at the AAN in April that tries to break these boundaries that we have on seeing MS as a relapsing remitting MS, primary progressive MS, secondary progressive MS. And the importance of that is that hopefully we'll explain not only why some clinical trials don't work for primary progressive MS, but also may explain why some patients, when they reach certain stage in their disease, we keep doing MRIs and they aren't changed, and yet patients are getting worse. And we usually don't know exactly how to explain that. And this model addresses some of those factors as well. So this slide shows the traditional view of MS, in which what we tell our patients, once you have your first clinical event, which is shown there as this bar. Can you see the pointer? Here you go. That's the first clinical event. We call that clinical isolated syndrome, and it's usually a relapse, most of the time optic neuritis, but could be virtually any symptom. From then on, the patients, if they don't receive any treatment, they will have approximately 1 relapse every 18 months. in their natural history. And as you can see, after each relapse, they have a risk of accumulating disability that then leads to a secondary progressive phase of the disease. In the yellow arrows, you can see the MRI activity. MRI is usually more active than clinical activity, and that's why we say in the first 5 to 10 years, we expect anywhere from 5 to 10 new lesions every 18 months. So, and we usually try to address that early is better in MS, so the earlier we start treatment, the better the clinical outcomes are, but truly it's never too late to start interventions or treatments. But this is a new model, and this is it's called a topographical model. This was described and developed by Steven Krieger at Mount Sinai in New York. And it's a very visual and easy to understand model. So let me try to explain that. So basically, if you imagine MS as a disease course as a swimming pool, and a swimming pool that has a water level on the top, and the bottom of the swimming pool has a shallow area and a deep end. And the difference between the two has to do with different anatomical regions on the brain and central nervous system. So the shallow area are the optic nerve and spinal cord, areas that are very likely to cause symptoms if patients have lesions. Whereas the deep end is the cerebral hemispheres, the actual brain itself, which patients can accumulate a lot of lesions, and early on, those lesions will not cause symptoms. And then you have the water level here, and that represents the clinical threshold, how high a lesion has to be in this model in order to surpass the threshold to cause symptoms. So as you can see, if you have lesions, and those are represented as these spikes in the water, if those lesions surpass the threshold, patients have symptoms. But as you can see in the model, there are all these lesions that accumulate very deep in the water, in the swimming pool, that they don't cross this threshold, hence they will not cause symptoms early on. Is that clear so far? Because there is more now. Things get complicated. As you know, we are a dynamic process, and our brain constantly is in a dynamic process. So what happens when we age? Well, the water level starts to go down. And that's the concept of losing brain reserve. So the amount of water that we have in the pool is different, and it varies from patient to patient. But as we all grow older, our brain gets smaller. The rate of brain atrophy is estimated in healthy individuals to be 0.2 to 0.4% per year. Men will lose brain faster, so sorry for that. In patients with MS, the rate of brain atrophy is 0.7% per year. So as you can imagine, that brain atrophy is faster. In patients with MS who are treated with medications, the rate of brain atrophy actually equals, in some cases, the rate of brain atrophy in healthy controls. And that reminds me that we are actually conducting the first study looking at that here in Colorado. We are looking at patients that receive a medication called natalizumab for at least 2 years, and we are comparing the rate of brain atrophy with healthy volunteers. And we need more healthy volunteers to enroll in the study. So any of you guys are here that don't have MS and want to volunteer their time for research, please let us know, because all we need from you is a couple of MRIs and questionnaires. And what we are trying to actually prove is that when patients are stable with their disease course, the rate of brain atrophy actually equals, if not hopefully better, than the rate of brain atrophy in healthy volunteers. So let's go back to the model. So as you age, and as the disease continues to go in the natural course, the water goes down. And that's why patients start to unfold symptoms and problems. Even though if we do MRIs, the number of lesions remains the same. The change in the water starts to unfold symptoms from lesions that patients had before. Is that clear? Can you improve the amount of water that you have in the pool? Yes. And that's the whole concept of brain plasticity. Can you stimulate more brain reserve? Absolutely. What are the things you can do to do that? Exercise, diet. Those are the main two factors. We know that up to 5 hours of aerobic exercise per week positively impact the brain reserve. We know that healthy diet, and we talked about the Mediterranean diet, avoid trans fats, avoid processed foods, no salt, no smoking. All of those things are going to improve the water level in the pool. So some of you probably had an infection at some point. And when you have an infection, all of a sudden, your eye gets blurry, and you get tingly, and you get weak. And you go to the doctor, and the doctor do an MRI, and there are no new lesions. And then the infection goes away, and the symptoms go away. So what happened there? There is a sudden drop on water because of all these factors or this systemic inflammation that we have. And that sudden drop of water is what we call a pseudo-relapse or a pseudo-exacerbation. Then the infection goes away, the water goes up again, and the symptoms go away. So this model it's very simple, but it's beautiful because it explains many things. And what happened with progressive MS patients? Are they different to relapsing? No. Probably in those patients, what happened is that all the lesions that they had were in the deep end of the water. And because of that, they never had relapses early on. But as the disease continued to progress, the water goes down, that unfolds disability later on in life. So this is one of my last slides, and I think I have the 5-minute mark, so I should be quick now. But just to show you that we know that MS is more common in females, as I mentioned before. And those are the symptoms that we know MS patients can have, virtually any symptom. The most common ones are sensory symptoms, numbness, tingling, visual symptoms, motor weakness, spasticity, difficulty with ambulation. And this is just to show you a visual example of what happens inside the brain. So we have inflammation early on in life in MS, anywhere from diagnosis to 20 years from diagnosis. That's a highly inflammatory phase of multiple sclerosis. At the same time that there is inflammation, there is partial repair or regeneration. Our brain, again, is very plastic. It's going to try to repair as much as possible. But as that process continues, there's going to be a second phase of degeneration. So that point is when clinically patients start to have more disability, start to have less relapses, less lesions on the MRI, and the water in the pool goes down, and we clinically label this stage as secondary progressive multiple sclerosis. So this is just a cartoon to show you what happens in that interplay between the immune system and the brain. And here in the top, you have a blood vessel, and this is the brain inside. And there's a tight area called the blood-brain barrier, which is here. And this blood-brain barrier usually is very tight and does not allow immune cells to get to the brain. Under certain circumstances, immune cells will be able to go through that. And this is a T cell trying to get into the brain. And when that happens, that T cell, if that's an autoreactive T cell, a T cell, the memory cells that we talked before, that is going to look for anything that looks like an Epstein-Barr virus, for example, and encounters the myelin and gets confused, start to destroy the myelin thinking that it's a virus. So there is an activation of other cells inside the brain that are going to try to stop that. But in the process, there is a scar that is left. And just to show you this is a courtesy of Bruce Trapp at the Cleveland Clinic, and it's a beautiful example. So this is an actual photography of a slice of a brain, and you can see here a blood vessel, and you can see the axons in red. The axon is the core of the nerve, and you can see the myelin in green. So you can see in one transection of the brain, you can see millions and millions of axons and myelin. So what happened in MS? Well, you have the immune cells that start to get into the brain from the blood vessel. And as they go in, they're going to cause damage. And the damage you see here, and this is real. This is not a cartoon just made up. This is a real example. And as you can see, there is demyelination or loss of myelin around the axons. In addition to that, there is also axonal loss because the distractions sometimes go beyond just the myelin. And if you put this slide into an MRI, you're going to see a white dot. So every single white dot that you see here are scars. That is a consequence of that interplay between dysfunctional autoreactive immune cells and the brain. And as you can see here, and I have to give credit to Tony Trabulsi at the Vancouver Institute that gave me these slides, is a longitudinal MRI assessment on the same patient that went from a clinical isolated syndrome, first event, relapsing remitting MS, and secondary progressive MS. So you see a clear accumulation of lesions in the brain, but also, let me quiz you here. How do you see the dark areas in the brain? Those are the ventricles. Do they get smaller or larger? Larger. It's always a second option. That's a tip that I give to my students. It's always a second option, right? So if the spaces in the brain, those fluid-filled spaces in the brain, get larger, what do you think is happening to the actual brain? Gets larger or smaller? Great, second option. So this is a clear example of brain atrophy over time. So one way that we have to indirectly measure brain atrophy is by the size of the lateral ventricles. But as I mentioned before, in our study, we're actually doing a quantitative analysis of brain atrophy. And I think I'm done here. This is just to show you a gadolinium-enhancing lesion. Again, the meaning for that is breakthrough of the blood-brain barrier. So I'm going to stop here. Take-home messages: be as healthy as you can, exercise, watch your diet, don't smoke, watch your sodium content, and keep educating yourself. I do believe that the first and best treatment for MS is education. Thank you for your attention.
Thank you, Dr. Miravalli. If you would like to hear more from Dr. Miravalli, he is hosting the Conversations on MS, an intimate setting where you can ask your MS-related questions free of charge this Tuesday, May 19th at the Ross Cherry Creek Library from 6 to 7:30 p.m., and you can see our website for registration information. And now I would like to introduce our next presenter, Dr. Enrique Alvarez, who will present a case study on symptom management. And after Dr. Alvarez speaks, we will have a 15-minute break.
Thanks. Good. It's great to see so many people show up on a Saturday for this summit. And we'll switch focus a little bit to talking about symptom management for people that were here at the last one. You might recognize the first few slides. I promise it is different afterwards. We're going to be taking a case and talking about fatigue and trying to kind of look at it from our side as to all the different things that sometimes can cause some of the symptoms for just one symptom. It is great that every volunteered that they were taking vitamin D, because this will be an active participation session. And if you don't participate, we'll be done really, really fast. With that being said, then, let's see. So when we talk about lesions, and you had already a good discussion about this earlier, we talk about different parts of the brain controlling different things that our bodies do. And maybe there's not so many differences between men and women, but different parts of the body, especially when we look at the surface of the brain, do control different aspects of what our bodies do. And lesions can sometimes control the symptoms or affect symptoms depending on where those lesions are. However, most of the lesions don't affect the surface of the brain as we normally would see in the other parts, but tend to affect sort of the wiring and the connections between the different parts of the brain. Meaning that a lesion here might affect everything that's connected from this side to the other side of the brain, things that are from the front to the back part of the brain. And so it's really sometimes hard to kind of tell what the symptoms will be from MS lesions. To kind of put it into ways that's a little bit easier for me to understand and a lot easier of a map, when you look at lesions and where they affect, it'd be kind of like cutting transportation lines in the US or somewhere else. And we'll be showing a little bit about this a little bit further later. So you already saw a slide like this. These are many of the symptoms that you can see in MS. And one of the most common ones is fatigue. The point of this session will basically be to kind of emphasize that things affect each other and that things are usually never as easy as they might seem. So that if we do have a patient who has fatigue, that's going to affect a lot of other things that a patient might experience. For example, if you have extra fatigue, you're depressed, or other things like this, you're probably not going to be exercising as much. If you don't exercise as much, your tightness or that spasticity might be getting worse. You might have more problems with constipation, things like this. If you have problems with constipation, more tightness, you're not moving around as much, you might also have more problems with bladder function. If you're getting up in the middle of the night because you have to go pee, you might have problems with your sleep. It might be hard to get into the deeper stages of sleep or the REM. If you're not sleeping well, you're not going to be thinking very well. If you pull that all-nighter the night before, that following day can be a little bit rough. And so then that feeds into making your fatigue even worse. And this is a lot of times what we describe as that downward spiral of things. And how to fix it, a lot of times is fixing something else down in here instead of the actual issue with fatigue. All right. Fatigue, we always know what it is, or we have a feeling. It's feeling tired to some extent. Of course, we have to come up with a very fancy definition for that. So that's up there. That's what I mean by fatigue. It's very common. 3/4 of patients with MS will talk about having fatigue. Probably 100% of new mothers will talk about fatigue. So it's a very common symptom for a lot of patients with all kinds of other conditions and sometimes just with normal life. In MS, however, fatigue can precede all the other symptoms about 30% of the time before they're even diagnosed. And 40% of MS patients, depending on the survey and everything else, will say that this is their worst symptom. All right, so poll question number 1 for the room would be, so how many patients here will describe that they have fatigue? I'm glad I picked the right symptom. Perfect. All right, so let's kind of talk about this and kind of try to peel off some layers around this conversation in clinic. Oh, all right, we got that one covered. So if you're tired, maybe we just need to give you some more extra energy. Does that seem like a pretty reasonable option? It might be for some people, right? But let's try and peel off some of those layers. What if we find that the patient's only been sleeping 3 hours a night? I already kind of gave you that hint, right? So maybe in that case, maybe we need to consider trying to do something if we should do sleepers, right? Something that allows a patient to go to sleep. The combination that bothers me a little bit, and I think a lot of my colleagues, are patients that are getting things that help them get revved up in the morning, and then combinations of stuff that at night make them go to sleep, right? And so it's like if you need one or the other, that makes sense, but we shouldn't be kind of adjusting things. We do that in real life sometimes. We might take Benadryl at night, hopefully not very often. We might do coffee in the morning to help us get going. But as far as kind of, big medicines and things like this, we should try and hold off on that because they all have their side effects. What if we now find out that the reason they're only sleeping is because they're anxious or having spasms? Right, so sleepers, as you all guess, is probably not the right answer, but we need to figure out what's keeping them at night. Are we trying to figure out if they have issues with their mood and try and figure out what's keeping them up at night, if it's the finances or other parts of that? What if they have cramps or pain or things like this? Then we might need to look at those kinds of symptoms and treat those things so that they can then sleep and then get more energy in the morning. As often as the case, it's always easy for us to keep adding drugs. It's probably the thing that gets us out of the room the fastest. I got the drug for you, that kind of thing. However, a lot of times less is better, and it's trying to figure out and going through the drug list to try and figure out which are the medicines that maybe we can peel off to kind of make life a little bit better. All right, so how many people in here are on a muscle relaxer? Baclofen, tizanidine? Probably 1/3 to 1/4. How about pain medicines, especially things like gabapentin, amitriptyline? A little bit less, but still quite a few. How about things like, we try and limit some of these, but we still see a lot of patients on Klonopin, Valium, Xanax, alcohol. No, just kidding. All right. So what else do we want to do? Right, so a lot of times we do use these medicines, but maybe we find out that the patient's taking it in the morning and not at night. Right, so they're taking a medicine that can cause a lot of sedation, and they're just simply taking it in the morning because that's what the thing said, it just said once a day, and they didn't quite realize, and so now they're just kind of sleeping through the day, they wake up in the night, and now they're just all hyper, and the cycles get messed up. So figuring out what drugs they're on, how they're taking their medicines is very important. That was just a partial list. I mean, even some of the medicines for treatment of MS, interferons, for example, can cause a lot of fatigue. So that has to be looked at. And then just the other drugs that we use. Are we taking caffeine towards the end of the day? Are people kind of just crashing from taking some of the illicit drugs? You know, those kinds of things. So it's trying to figure out that people are taking the right medicines at the right time, at the right doses, and things like that. We started asking a little bit more, and we found out that the patient has a cough and a fever for the past week. If I had the flu, I'd probably feel fatigued as well, right? So trying to make sure that there's nothing else that's kind of going on. Unfortunately, there's not a lot of stuff for this, right? It's the short-term stuff. It's kind of real life. We might be able to find Tamiflu or something like this for the flu, but for the most part, we might be doing chicken soup, ibuprofen, drink lots of fluids, you know, the very advanced medicine here. You know, I might have to pause the visit and kind of realize, wow, the room is really hot. Let's open the door to the room. Just had to do this the other day in clinic, so it does happen, and that can increase fatigue, right? Over the summer, patients with a lot of heat, that affects MS a lot. Patients might describe that they feel better over the summer. Not everybody reads sort of the medical book, and so some people will describe that the cold really affects them, and the winter's the worst part of the year. And so if that's the case, maybe we need to be looking at, you know, trying to see what we can do to help out as far as regulating temperatures in the house, staying hydrated, cooling vest, things like that. Now it's the patient that asks for the break. They're having to go because they got to go. And so, you know, maybe you find out that now they're just constantly going. And some of that then implies that they're probably having to get up in the middle of the night to go to the bathroom. And if they're getting up every 2 hours, the chances that they're getting any decent sleep that night, probably pretty low. So if that's the case, then we need to start looking at trying to affect the pathway, which is a really long pathway that controls the bladder. And it goes basically from the tip of the brain all the way down the spinal cord into the nerves that control the bladder. And this gets complicated because it might be something that controls how strong the bladder is or how strong that valve is at the very end of the bladder that lets urine come out. So it might be a weak bladder or too strong of a bladder, those kinds of things. The other thing that we need to look at is kind of when are people exercising. So sometimes people might be exercising in the morning, and that might be great, but it might be wearing them out for the rest of the day. Might try to exercise at night. If that wears you out, then that might let you go to sleep. And then to combine things, not only might you be waking up at night, but it might be because you have an infection. And so one thing can be affecting sleep in a variety of other things. And so then antibiotics might be the right answer. So we do need to control relapses because many of these things are controlled by other parts of the brain. And the best thing to try and prevent some of these things is just preventing those attacks, the stuff that Augusto has been kind of talking and affecting those pathways with the biology. We talked about the map. So let's say you're trying to get from where I went to college in Fargo, North Dakota State, go Bison, and make it down to where I went to medical school here. I take the most direct path, maybe not the most direct path, but you know, the shortest route that I could kind of get on the interstates. But now let's say you have a lesion that maybe affects, what was that, Omaha, and I can't get it through that way. The alternate routes aren't too bad. I can still kind of make it through. Say there's a lesion, and now my shortest route is going through here. You get another lesion, and now I have to go all the way through here. That's a long way to try and make it. I might be able to get the signals through. I might be able to get my legs to work or things like this. But the amount of energy that my body's expending to do this is taking a lot more effort. And this is kind of what we talk about energy conservation. Sometimes it just takes more energy to get something else done. Think about the example of somebody who just has one arm and they're trying to do something. it's going to take a lot more energy for that person to do it than somebody who has both arms, right? And so that, again, things that we need to do as far as trying to control symptoms of fatigue. And so a lot of times I'll describe, before we can kind of really delve into a lot of symptoms, the thing we need to do is control your disease, because otherwise we're not going to make a lot of headway. So what causes energy fatigue? We've talked about a lot of different things already, and we've seen how they can kind of play out a little bit. And so these are things that you can start to see that we can try to affect with some of the approaches in clinic. A lot of times it's not stuff that we do, but the people that that work around the clinic and working as a team to try and affect these things. It might be working with urology to work on those bladder issues. It might be working with physical therapy. If we can get a ankle foot orthosis, one of those ankle braces, and let somebody walk a little bit more efficiently without tripping, for example, that might let you walk longer or more efficiently without tripping and things like that. Trying to figure out when to exercise, how to cool things, what's the right equipment, trying to get the right amount of drug at the right time of the day again. All these things are the pieces of the puzzle that we really need to work on to try and help with fatigue management. There's a lot of stuff that goes into trying to make these decisions. We need to try and, of course, minimize discomfort and things like this. We need to try and improve the function. We need to try and limit side effects of those drugs. It might be good to try and go up on the baclofen. The spasticity might get a lot better. But what if the sedation is just so much then I can make them walk, but now they're so tired that they're not going to walk. And that's the balance that sometimes we need to work on. I think the other thing that we need to really set up sometimes is realistic expectations. There's only sometimes so much that we can kind of do. If you make somebody's spasticity really much better, maybe then their weakness starts to show, and you're actually using that spasticity to try and be able to walk. So MS symptom management, I think, is one of the cores of things that we try and work on. And it involves a lot of different things, including patient education, physical activity. Augusto's already talked about the importance of exercise and how important that really is. Using specialists. I don't know everything, and so other people, I really rely on them to try and help me out. And then kind of prescription medicines is possibly, hopefully, kind of a last resort if that's the case. So we need to recognize those symptoms, and hopefully we're asking those kinds of questions. There are treatments for many of the MS symptoms. Because there's so much stuff that goes into these symptoms, we will touch base on a lot of things. But the realistic expectation a lot of times is to pick one or two things that we really can kind of focus on during a clinic visit to try and figure out really what the best way is to approach it. We might need to, again, kind of go to a specialist and set realistic expectations. I'll talk briefly because we have a session coming up on disease-modifying drugs. The one symptom drug that's very specific to MS is Ampera. This is a lot of times referred to as the walking medicine. And what it allows to do is basically signal sometimes. So this is a little bit from the same guy that Augusto was showing his picture from Bruce Trapp. This is a nerve that underlying it is only in red, and then we talk about the insulation of that myelin and red together that make yellow. And there's little areas where they're kind of starting to kind of peel off that myelin. That's that demyelination that we talk about in MS. If the nerve is still connected, but we don't have that myelin around it, things might make it through here, but they might be very inefficient at doing so. This medicine can sometimes then help that signal make it across and jump and skip these areas. However, sometimes that nerve is also broken, and then that makes it really hard for those signals to make it through those areas. And that's one of the issues why the drug doesn't work in everybody. But I think for sometimes it is something that is worth a discussion and seeing if it's worth trying. The concern is, as signals make it through these nerves, is if you do that a little bit too well, you end up with seizures. And so there is a small risk of seizures with these medicines. And that's something that needs to be discussed as well. All right, so hopefully kind of try and get you back on schedule with the break. If there's any questions, we'll hold them actually until the end when at the question panel. And with that, I'm done. Enjoy your break, and we'll see you back in.
Thank you, Dr. Alvarez. Just as a reminder, later this morning we will have that question and answer session where all of the presenters will return to the stage for your questions. Everyone at the MS Center wants to thank you for your participation in the Education Summit. Events like this are made possible with the help of our exhibitors and supporters. If you've enjoyed yourself and would like to support this event, there are materials inside your program folders. We will now have a 15-minute break. Restrooms are located outside the ballroom to the left, and please take a moment to visit our exhibitors. Thank you. Our next presentation is brought to you by the co-directors of the Rocky Mountain MS Center Clinic at the CU Anschutz Medical Campus, Dr. Timothy Vollmer and Dr. John Corboy, on early effective intervention. After their presentation, we will begin the question and answer portion of the program. Please continue to submit questions on the note cards located in your program folder, and our volunteers have additional in case you need them. Welcome, Drs. Vollmer and Corboy.
Thank you very much. Well, I'd like to welcome you all to this program again. We very much appreciate your interest. Also, as we do these programs twice a year, we'd like to try to improve them as much as we can. So if you have ideas or suggestions about how we can make them more effective, more useful to you, please let us know. So you've heard talks already about the basic biology and the symptomatic management of MS and some of the basic concepts that we work with. I'm actually not going to talk so much about treating patients with MS. Instead, what I'd like to do is to see if I can convince you that we need your help to help change practices in the United States, Canada, and Europe in terms of how these drugs are made available to patients with MS. And basically what I'm going to be arguing is that if we could get the third-party payers out of the way, so the insurance companies, the centralized healthcare systems in Canada and Europe, and let us use the drugs in the most effective way that we know that we can do it, we could fundamentally change the course of MS in one generation. Okay. Before I do that, we have an advertisement. So we are doing some studies on how brain volume changes over time in MS patients who have been on some of the highly effective therapies that we use for more than 2 years. There is brain volume data from these studies. In the first 2 years, we know that these drugs can slow down the rate of brain volume loss. What we don't know is that the patients that are doing well on these drugs after 2 years, has their brain volume loss returned to normal? And I'll talk more about brain volume loss as I go into this, but brain volume loss is the most powerful predictor of long-term outcomes, and so that's a key monitor for us. And to do this study, we actually need people who don't have MS, but are in the broad age range of MS, to volunteer to be healthy controls. And what would be involved is they would have 3 MRIs over 2 years, 1 MRI a year, on our research scanner. There's no injection of dye, it's just the MRI itself. And then they would fill out some questionnaires, the same questionnaires that our MS patients fill out. And they would be the group we would compare the MS patients to see have they really normalized in terms of what's going on in MS. So if you know of anybody that might be willing to volunteer their brain for an MRI and to do some questionnaires for us, let us know, or have them contact us. So I'm going to argue that early intervention in MS can fundamentally change the outcome, and I'm going to go through the background for this relatively quickly. First, you've already heard these terms, but I'm going to use 2 terms, neurological reserve and neurological resilience. And by neurological reserve, I mean this is the ability, my pointer's out, the neurological reserve is the ability of the brain to compensate for subclinical changes in the brain. So all of us have changes that go on in our brain, it's just part of life. But in MS, they're accelerated. And the brain has the ability to mask that and allow you to keep functioning normally, so you're not even aware that there's been some damage or you've lost some nerve cells. That's neurological reserve, and you have a certain capacity to do that. All human beings do. There's also a concept of neurological resilience that I've been talking about for the last 6 months or so, And this is the ability of the brain to recover from injury. So this is a situation where somebody has something happen to them, they develop neurological symptoms, and then they recover function. The brain actually has quite a bit of neurological resilience, particularly in early life. So we all know that MS tends to get stratified into these different types of relapse-remitting types and primary progressive types and secondary progressive types. The main point I would like to make to you is that people argue that these are different diseases. They're not. They're exactly the same disease. The difference is that the patients that have progressive forms of the disease are on average 10 to 15 years farther into their disease course than patients who are starting out with their relapses. And the reason that that's important is that over that first 10 to 15 years, people with MS are using up their neurological reserve, and that's why they enter the progressive phase of the disease. It's when they enter progressive phase of disease, that means now the brain doesn't have enough neurological reserve to mask what's been going on underneath, and I'm going to tell you more about that. So what I'm arguing is that what we need to do is to take these patients at their very first event that leads them into our clinic. That could be a relapse. It could be a symptom like fatigue or cognitive problems that leads to an MRI, or it could be just an MRI that was done for headaches and happens to identify MS. So the point being is we want to identify MS as early in the disease course as we possibly can and start treatment at that point to preserve brain volume so people don't go into the progressive forms of the disease and in fact can age normally and do things in their 60s and 70s and 80s that they would otherwise normally do. Now I'm not saying that we wouldn't treat everybody. We do want to treat everybody. What I'm trying to make an argument for is that we want to convince the health insurance industry and the centralized healthcare systems that they must let us use the most effective therapies out at the very beginning. So this is a reason from a societal point that they need to let us do it. So this is a study out of Sweden, I believe, and they're looking at the cost of MS overall over a lifetime. And what you can see here is that outpatient care is about 5.6% of the total cost. The drugs that we use is about 11% of the total cost. But if you look over here, this is long-term sick leave and early retirement costs. This is short-term absences. These are services like physical therapy, nursing services, getting wheelchairs, those kinds of things. And up here is hospitalization. So if we actually took patients at their very first attack and were able to treat them with a drug that had a 90% chance of preventing them from going into the secondary progressive disease and developing fixed disability, basically all of these costs disappear. And that would be a major benefit for society because society is paying for these as well as the individual families. So when we think about the treatment of MS, it's important for us to help healthcare policies, people, and insurance managers to understand a few things. First is that MS is not a disease of the white matter. It's a disease of the entire brain, spinal cord, and optic nerves. It's attacking neurons just as much as it attacks the myelin. But the attack on the neurons is the most important part of the disease, and it's the least monitored, least understood part of this disease. Also, you've already heard, most of the disease is clinically silent. So the brain is having 9 to 10, 20 lesions for every clinical attack. And the brain is shrinking as a result of those attacks, and I'll show you that data. But it's because the neurological reserve is masking them, patient and society doesn't see it. And then also, it's very important for people to understand that the inflammatory attack on the brain is actually decreasing as a function of age. So if you let patients accumulate damage over the first 15 years of their disease course, and then you try to intervene, you're intervening in the least effective phase of the disease because there's not much inflammation around anymore. So anti-inflammatory therapies don't have a very big effect at that point. So I've already talked about this. Nerve cell loss is not a secondary thing. It occurs right from the very beginning. You've already heard this. The brain is shrinking at an elevated rate. This is clinical isolated syndrome, which are patients with the very first attack. Their brains are already about 0.4% smaller than they should be. And this is that very first event. So the point of this is that a clinical event represents an inflammatory event that occurred in a particularly sensitive area of the brain. But most patients, when they come in on their MRIs, they have half a dozen to a dozen or more other lesions that they weren't aware of. And those are the ones that are causing the brain to already lose volume. Now, 0.4% is not very much, but it's important as it accumulates over time. And that's true throughout the course of the disease. Most people in the world believe that the rate of brain volume loss increases as one ages because there's a separate phase of the disease called neurodegeneration. There isn't. All of the loss of brain volume is related to inflammation. I'll show that to you. And in fact, as inflammation goes down in the older age groups, the rate of brain volume loss actually decreases a bit. So this is a complex slide, and the only point of it is that we have lots and lots of research telling us that it's damage in the neurons, the gray matter of the brain, that actually drives disability, and not damage in the white matter. So these are called Spearman correlation coefficients. They range from 0 to a 1. 1 means there's a perfect correlation between whatever you're studying and whatever the outcome is. 0 means there's not any correlation at all. So this is in white matter, so changes in the white matter and their ability to correlate with clinical measures. So this is walking. This is a combined scale that has an upper extremity function, 9-hole peg test, timed 25-foot walk, and a cognitive test called the PACE-AT. And what you can see is that these clinical outcome measures measure with change in the white matter of the brain at very low rates, 0.03 up to 0.2. However, the gray matter fraction, which we can actually, on your MRI, measure how much gray matter you have in cubic millimeters, it's actually quite easy to do, and changes in that compartment correlate with these measures by a 0.4 to 0.6 range. So that means they explain 40 to 60% of the variance. And in fact, in another recent study, if you combine the rate of brain volume loss with the number of new lesions forming over a 2-year period of time, that explains 90% of the reasons as why patients get worse in terms of functional ability over that 2-year period of time. So we know that the inflammation and the change in brain volume is really key to managing this. So we've already heard that most of them are silent. This is just a slide showing that the more lesions you have, this number of lesions on the bottom here, by volume and by number, the faster the brain is shrinking. So if you have very few lesions, the brain volume is not changing very much. If you're getting a lot of subclinical lesions, then it's changing at a much accelerated rate. The brain compensates through cortical remodeling. So this is the ability of the brain to mask that disease. And there are ways to enhance that, and you've heard about that a little bit already. The fact that disease is decreasing as a function of age is well documented. This is looking at relapse rate. So as patients get older, the most disease activity is actually in the 20s, and then it decreases steadily after that. So by the time people are 60, their disease activity is decreased by 60 to 70%. And many patients out in this category appear to be through the inflammatory phase and are not having any inflammation at all. The disease is over. So whatever damage is caused by that point, it's caused. But we think that there's a portion of patients out here that don't need to be on these therapies because they're not in the inflammatory phase of the disease anymore. This is looking at MRI disease rate and basically looking at different age groups. And the point is that actually about age 35, the number of active lesions on MRI begins to decline and decreases to about 20%, 10 to 20%, ultimately of what they would be at younger age groups. So this concept of neurological reserve, again, it's the capacity of the brain to compensate for subclinical disease activity. It's present in MS. So in MS, if we preserve brain volume, people are better able to compensate. They perform better cognitively, so they have less cognitive problems. And if we preserve brain volume, they can compensate for the white matter lesions that are caused by MS better. So these are patients that have larger brains and have had increasing number of white spots on their MRI, and they really didn't change in their function in this cognitive test. Patients who already lost brain volume, though, were not able to maintain that function, so they've lost cognitive function. And this is the argument for living an active, healthy lifestyle. So here we're looking at people who are exercising, eating healthy, and living an active lifestyle, and the more you do that, the better you have cognitive performance, better able to perform on this test. Also, if you have this active lifestyle, you can help buffer the increasing number of MS lesions in the brain much better than people who don't live an active lifestyle. So this is an argument for the comprehensive management of MS. And the argument for, and this is some of the factors behind it, so how much neurological reserve you have is dependent partly on genetics, partly on early brain development during embryology, early life experiences, nutrition, infection, enhanced activity, but also there are things that happens to you that decreases your reserve. So playing pro sports, particularly National Football League, is not a good thing because it decreases that. If you exercise, again, you've heard it improves almost everything, and as you've also heard, it increases your neurological reserve. So exercise is just as important as the prescription drugs that we prescribe. I would argue probably is more important in affecting the long-term outcome. The other reason for exercising and eating healthy is preventing development of hypertension, diabetes, cardiovascular disease, and obesity, because if you have those, they increase your risk of being disabled. So people with the same MS, if they have these comorbid diseases like diabetes, diabetes itself doubles your chance of being disabled from MS. And the reason is that these other diseases are also stressing your neurological reserve. So you've got the problem with the MS stressing it, now diabetes stresses it because when your blood sugars drop too low, neurons die, and that's magnified because of the interaction with MS. Same is true for microvascular disease that occurs in hypertension. So, as I said, when patients exhaust their neurological reserve, they enter the progressive phase of the disease. We have a lot more research we need to do to fully be able to treat that form of the disease, but we have improved treatments for it substantially in recent years, but we still have a lot to do. But what I'm arguing is that if we prevent them from losing that reserve, then we don't have to deal with the problems of secondary progressive disease in the next generation. And there's some predictions about loss of neurological reserve. One is neurological reserve is important to allow all of us to age normally and be healthy in late life. If you want to be an active grandparent, you need to preserve your neurological reserve. And if you consume neurological reserve early, then you end up having aging effects of the nervous system show up much earlier. So rather than having them show up at age 65, they may show up at age 45. Therefore, we want to terminate inflammation in all forms of the disease as completely as possible, and the drugs that we have different abilities to do that. And we need to be, as clinicians and patients, we need to have the freedom to be able to choose the right patient for the right drug, or the right drug for the right patient. And then this one down here, if you've lost neurological reserve, I would argue that you're also likely to have lost resiliency or the ability to recover from injury, and because the biological bases of these are very similar. And we actually have direct evidence for that. And that's here. This is a study using a powerful drug, alemtuzumab, where they had a 1-year observation before treatment, and these are relapsing patients and these are progressive patients. They then treated them right here. And what you see is that the relapsing patients actually improve in function. So going down on this scale is a very good thing. It means your disability score is going down. You're more functional. And they continue to improve every 6 months out to 3 years. And this is what we see in the clinic. If we use highly effective therapies in early phase disease, by 2 years, almost everybody comes back in and says they're better. And many of the newly diagnosed patients come back in and say, I don't feel like I have MS anymore. And that's why we're working on this so much. But if they've already entered the progressive phase of the disease, they dramatically decrease the rate at which they're getting worse, but they're still slowly worsening. What I would argue is that this worsening is no longer the inflammation from MS, it's the effect of aging unmasked. Because they're in the progressive phase, they don't have neurological reserve, so even if we shut off the inflammation, they're still going to slowly worsen over time. Now, they can minimize this, again, by living that active, healthy lifestyle. Exercise builds reserve, and so that's what we need to help work on, is get more access to exercise and active lifestyle out here to help combat that. But we are working on therapies that are reparative therapies that may also help us with this form of the disease. And so to summarize here, we have, all of us, normal, healthy people, we have relatively stable brain volume until about age 30, and then they gradually start to fall off. That's just being human. That's just what happens to us. But in MS, they're going down at a much more rapid rate very early in life, and that's due to inflammation. It's not due to anything else. It's due to inflammation. And our goal is to treat early and stop that so that it then goes back to a normal curve. Now, I don't know for sure that we can get there. We're doing studies right now to see if we can do it. So that study that I talked to you about, healthy controls, is part of this effort. And if we're not quite there, if the drugs that we have don't allow us to do this, we're in the position now to do combination therapies, because there are several other drugs we can use with our anti-inflammatory drugs that would help improve this outcome. Drugs, simple drugs like phenytoin, the statins, and a drug called laquinimod. So we need your help as you talk with your friends, families, your politicians, health managers, to try to get them to understand that all these drugs are not created equal. And there is no single drug that's appropriate for every MS patient. But we do have drugs that if we moved away from the interferons and Copaxone and used the newer drugs, we could fundamentally change the outcome in MS and dramatically decrease the possibility that this disease is going to fundamentally change somebody's life. Thank you very much.
Thanks for coming. I'm John Corboy. Thank you very much for taking time out of your day, taking most of the time out of your day. And who's got the slides? Oh, it just automatically goes forward. Perfect. All right, so Dr. Vollmer has very nicely set up the logic for what we think is happening with MS over the course of someone's lifetime. And my job today, in about 15 minutes or so, is just to talk about the so-called disease-modifying therapies that are presently available that can potentially alter the natural history of the disease. So These are my disclosures. And MS treatment, as has already been alluded to and discussed multiple times here today, can really be broken down into several categories. So just behavioral changes, exercise, sleep, use of vitamin D, no smoking, perhaps low salt intake, treating the acute attacks with steroids and other agents, symptomatic therapy, as was discussed earlier by Dr. Alvarez, and then so-called disease-modifying therapies that alter the natural history of disease, and that's what we'd like to talk about here right now. So the early approaches to treatments with potentially altering the natural history of the disease were based on whatever was then the then current concept of the cause of MS. And when we look at these in retrospect, they seem some sort of silly, but all of those were felt to be quite likely potential causes, and potential therapies were designed to deal with those. Moving more into what we think of as the more modern approach, we think of this as an autoimmune disorder, or at least one in which, even if the autoimmune attack is not primary, it certainly participates to a great degree. And we think that the alteration of the immune system is extremely important. All of the therapies we presently have are based on that. But the original studies were very nonspecific, using sort of very large hammers for very small nails, and were very nonspecific, affected multiple parts of the immune system, had many, many side effects, were not particularly successful, and were actually quite toxic. And some of these older medicines are listed here. And while we still may use, for example, cyclophosphamide or others intermittently, these have really fallen by the wayside. The lack of success led somewhat to therapeutic nihilism in sort of the 70s and 80s before the introduction of beta-seron, interferon beta-1b in 1993. The modern therapy concepts might fall into three broad categories of things that we might do to alter the way MS has its effects in the nervous system. One is to still continue to alter or subvert or suppress or somehow alter the immune system. And all the presently available medicines that we'll talk about, this is the way they work. But there might also be other opportunities available, and these things are under study. So enhancing the normal repair mechanisms, because there are a number of molecules that inhibit the normal repair that we all have and contribute to this concept of reserve. And then also potentially replacing damaged cells with stem cells. And we now have the ability to make, with so-called inducible pluripotent stem cells, cells that have already developed some of the characteristics of becoming nerve cells, not just bone marrow cells that might affect the immune system, but actual nerve cells. And we're highly interested to see how these new cells might be useful to replace damaged parts. But what we have available today is we have the ability to alter the immune system, and the focus right now is on those medications. And this is the modern era of MS therapy, looking at the various different medications since 1993 with interferon beta-1b, and then all the way up through 2014 with the last approval being at the end of 2014 when alemtuzumab or Lemtrada was approved in late December 2014 in the United States, about a year after it was approved in Europe. And then, of course, a couple of other agents that were manipulations of older drugs with glutathione acetate now in 40 milligrams and interferon, PEG interferon, which is essentially Avonex in a long-acting version, also approved in 2014. As Dr. Vollmer already mentioned, there are a variety of other medications which might be of use, including laquinimod, one he mentioned, that might be potentially useful as an add-on agent. So over the course of just really a little over 20 years, this is actually an incredibly impressive array of different medicines. And so what can we expect from these medicines, and how will we use them? The mechanisms of action, the MOAs of these medications, is different for all of them. Perhaps for the interferons is actually quite similar to one another, but all the rest of them are different. For example, fingolimod traps lymphocytes within the lymph nodes. Teriflunomide blocks the proliferation of reactive T and B lymphocytes. But I'd like to just focus briefly on the monoclonals. The monoclonal antibodies, all the ones that end in MAB, these are the more recent medications with natalizumab, alemtuzumab being approved, rituximab to be followed up by ocrelizumab and perhaps ofatumumab not yet approved, and declizumab, which also is not yet approved. The point is that these molecules all act in a similar fashion, although act differently by attaching to molecules on the surface of white blood cells, in the case of natalizumab, alpha-4 integrin, and then either stopping those white blood cells from being active or actually deleting them, removing them in the case of all of these other molecules. And this is just the example with natalizumab, how it works, but they all work in a similar fashion. And these are monoclonal antibodies. These are similar to the antibodies that your body itself makes as part of the immune system from the so-called plasma cells. Except in this case, they're directed specifically against these molecules on the white blood cells, in this case, directed against alpha-4 integrin. And in the case of natalizumab, then, what happens is that the natalizumab will attach to this alpha-4 integrin, which is on the surface of this white blood cell, and as opposed to allowing this white blood cell to go into the blood-brain, through the blood-brain barrier, into the brain or spinal cord, blocks it from doing that and blocks the effects. So in this case, it just blocks, but with the other monoclonal antibodies, it actually deletes the cells. So the biggest questions really with regard to the use of these medications are when do you start them and when do you stop them? And in terms of starting them, for nearly all patients, especially with early active disease, essentially as soon as we find out about the patient is when we want to start treating the patient for all the reasons that Dr. Vollmer described in great detail. And even if the first attack, even after the first attack, before a full diagnosis of MS, because the risk of having new disease activity is so high, we would like to treat. So we don't want to wait until the second, third, fourth attack. We want to treat early. It's not exactly clear how we're going to deal with secondary progressive or primary progressive MS, as Dr. Vollmer described. We think of this as the same disease, but move down the road a bit, and with the primary progressive MS patients just never having relapses. How we use these and when we use these and at what age we use these is variable and depends a great deal on the patient as to whether or not their risk of inflammatory disease activity still exists at a high rate, in which case using these medicines makes sense. We don't care about what the phenotype is, that is what you call the patient. What we care about is what is their risk of having new inflammatory disease activity. There now is some data, not very much, that suggests that some patients, especially patients who have reached maybe 55, 60, 65, and who've had no new inflammatory disease activity, may not really even need to continue to take these medicines and or just may not benefit from these medications. I would say that this is by no means a solid piece of research that we all agree upon. In fact, just a couple of weeks ago, we submitted a grant to what's known as PCORI to actually study randomized discontinuation of these disease-modifying therapies, but in a subset of patients, not in patients at high risk of new inflammatory disease activity, but in patients who are a little bit older, patients who've not had any new attacks or new scan changes for some time, and to see if it's safe for those patients, or if in fact they may benefit from going off the disease-modifying therapies. But I think it's fair to say the answer is we don't know the answer. So what are the goals of MS immunotherapy? It might be a lot of different things. It might be dependent upon who you talk to and when you talk to them, what the goals might be, and they may change over time. So certainly the medicines that are available reduce the number and severity of new attacks. They reduce the accumulation of new scan lesions and brain atrophy, which we think is so prominent. It's the single most important MRI feature that is related to prognosis. It can reduce disability progression, especially as related to the new relapses, and somewhat perhaps less so in older patients with no relapses. There's even data that suggests that early use can reduce mortality from the original beta-seron trials, the interferon beta-1b trials. Very importantly, it can also potentially stabilize or improve what we think of as quality of life or the patient-reported outcomes that Dr. Vollmer talked about that we would like to have patients participate in. We're very interested not just in counting the things that we can count, but we're also very interested in counting the things that are important to patients and make sense to them in terms of how their quality of life is. But ultimately what we're aiming for is we're aiming for lifelong brain health. And that's why if we think we can get somebody very early and institute exercise, dietary changes, control of comorbidities, and reducing inflammation at the maximum, we can have a significant impact to maintain that cognitive reserve for a long period of time. And so an important part of that is then how do we call treatment failure or treatment success? It's not really clear. There's not an agreed upon rubric by which we say this person has failed a drug, this person has not failed a drug. Is one little new dot on your brain scan failure of that medication? Is that equivalent to having 3 large attacks that leave a significant mark of disability? Probably not, but they may still each have some level of importance. So we need to figure out how better to measure this, and we need to figure out how the different changes that occur in terms of what we might think of as failure, how those relate to people over time. But we are moving towards a definition of something called either disease activity-free status or perhaps NEDA, no evidence of disease activity, or even NADA, no apparent disease activity. And this would be, in the first iteration, people having no new relapses, no change on what we can measure in terms of disability, either as measured by the doctors, the EDSS, or by the patients in the PDDS, the patient-derived disability scale, and disease steps, rather, and no changes on MRI scan. And you can actually, this is a post hoc analysis done by Bruce Cree at UCSF, looking at some of the medications that are presently available. I know this is a little small and you can't see it, but essentially looked at people who were showing freedom at 2 years compared to placebo, free from clinical activity or radiographic activity, or from both compared to placebo. And you can see that there's differences between the different medications. Just using cladribine, which is not approved by the FDA and will not be pursued, 44% of people at 2 years versus 16% placebo had no new disease activity and no apparent disease activity. And we're moving towards this as a potential way to measure, are these successful or not? But we might want to add other things. We might want to add in terms of disability, maybe a timed 25-foot walk, maybe a 9-hole peg test. That's a measurement of upper extremity function. Maybe with adding psychology or cognitive impairment as part of that as well, looking at any of a variety of different things. Or maybe even looking at different measurements of MRI scan functions, such as brain atrophy. How much time do I have? 0? Really? He went over. All right, so I only have about 2 slides left. So we're just going to go all the way through to the, we're going to go through the end then. We're going to, all these will be available where?
Next week on our website.
Next week on the website, these will all be available. So presently, so how do we use these? The present view of the world is primarily still, I think, dominated by so-called escalation therapy, starting with what are perceived to be, and are likely are, lower risk medications. And if patients do well, leave them alone. And if they don't do well, then as they have more problems, then use more effective therapy. And this is sort of a typical algorithm that might be used, that might be used where you would, for example, start with an interferon or glutathione acetate. If you do poorly, then try the other one that you didn't try before. If you do poorly yet again, then maybe go on to using a more effective therapy based on whether or not someone has been exposed to the JC virus or not, which is a risk factor for use of natalizumab. We would argue, and I think Dr. Vollmer laid out exactly the reason why we would argue, that this is not necessarily the best case. If, in fact, the medications that are used in the low-risk category were highly effective, that is, if 90% of people not only tolerated but did well with them, then this would make perfectly good sense. And in fact, that's what happens, for example, with using methotrexate with rheumatoid arthritis. It's cheap, old drug, relatively safe, and most people respond. Unfortunately, that is not the case for multiple sclerosis. And also, we're not talking about joints, we're talking about your brain. So we do not feel that this is an appropriate approach. And instead, we strongly believe in the high efficacy approach. That is, using the medications that are most effective at the front. That's when the risk is the highest, that's when the meds are most effective, and that's when you can have the greatest impact on achieving lifelong brain health and maintaining your cognitive reserve. Now, I don't expect you guys to all have all the answers to the questions we'll have later from looking at this, but we'll ask you questions later. And, but this is one model. There could be multiple models. This is one that you could use where you might, for example, distinguish people who are JC virus negative versus JC virus positive, and then go through this algorithm. If you need to use other therapies, use the other therapies, but use the most effective therapies that you can from the outset, and then hopefully maintain lifelong brain health. So we're going to have a break and lunch.
Question and answer.
Question and answer right now.
Yeah.
Tim, come on up.
Thank you, Dr. Vollmer and Dr. Corboy. Our registered nurse, Michaela Welch, and our volunteers have been picking up questions all morning, and we will continue to pick them up. If you have one, just raise your hand and we'll come around. So thank you, Michaela. Here you go.
Dr. Miravaya and Dr. Alvarez, could you join us up here? So all of the questions will be posted and answered on our website within the next couple of months, so we probably won't get to too many of them today, but we'll try. I'll pose this to Dr. Vollmer. Is there a way to measure individual neurological reserve?
It's a very interesting question. The answer is not directly. Is this thing transmitting? You can hear me in the back? Okay. So the neurological reserve is a concept. It pulls together the health of the brain, the size of the neural network, and its ability to compensate for injury. But you have to remember that the brain's made up of many different systems, and each system will have its own reserve capacity. So that might be a motor system related to walking, or it might be a visual system, it might be a cognitive system. So it's a very complex concept when you get down to the details, but it's fairly simple in its overall. So brain volume itself correlates with neurological reserve. And we know what your brain volume size should be for your age. There's been lots of studies about that. So we can do an MRI, at least at the University Hospital. We can get three-dimensional volumetrics from that. We can plot where your brain is compared to where other people without MS would be. And that gives us a strong indication of where you're at in that curve of losing neurological reserve. And we do those routinely on all the MRIs on our patients that get them at the hospital. We would like to be able to get it on any MRI unit, and it's perfectly possible to do that, but most MRI units don't yet think that's an important thing to do and aren't set up to do it. So I think that will change in the next year or two. So basically brain volume is the key right at the moment. We'll have other mechanisms in the near future.
Dr. Miravaya, are there genetic screening tests for MS?
They are. Can you hear me? Okay. Yes, they are, but we do not use them clinically. Probably most insurance will not cover for the cost of the test, and it's not part of the standard of care for diagnosis of MS to use genetic testing. As I mentioned before, the genes that has been identified as related to the risk of MS has to do with the way the immune system will respond to certain factors, but they are not considered to be standard of care for diagnosis, so we don't use them in practice.
Dr. Corboy, you had just discussed disease-modifying therapies. Are there patients managing their MS strictly with diet and exercise?
I'm sure that there are patients who are not using disease-modifying therapies, and that could be for a variety of different reasons. And some will be successful, and some will not be successful. The problem that we have is, unfortunately, we're unable to predict those patients that would not necessarily need or benefit from using one of the disease-modifying therapies. The unfortunate reality is that untreated, the vast majority of people will go on to have disability. A small percentage will not, and we're very happy when they don't, but the vast majority will. And the other unfortunate aspect is that the therapies that do presently exist are all preventative. That is, if you are trying to manage your MS, especially speaking when someone's newly diagnosed, if you're trying to manage that without the use of the medications, it's unclear what will happen, and if you have more problems, we can't make those problems disappear. We can't make the lesions disappear on the scans. We can't make a fixed disability go away with present technology. So our default view is that because the vast majority of people will have more disability as time goes on, that we should use all the different metrics that are available, all of the exercise and dietary issues, all of the taking care of comorbidities. They're all important, but so are the medications. And if I could also just add one small thing to Dr. Miravaya's answer as well. I completely agree with what he said, but we're also trying to use the genetic test, not necessarily to say you have MS or you don't, but to help try and define a potential risk profile based on genetic markers and perhaps environmental markers as well. And so one very important focus of research is to see if we can identify if there is a particular profile based on a whole host of factors, including the genes, to define someone's risk, especially in those individuals who we know are at high risk, which is family members of those with MS.
Dr. Alvarez, can you discuss using Impera in older patients?
Sure. So Ampera is, again, kind of the walking medicine, and I think its use can be expanded to a lot of other things. It's just that's kind of what allows it to be covered by insurance for the most part. But there's really no restriction as far as ages go if you're on other disease-modifying treatments or anything else like this. And so there's no necessarily restriction per age.
Dr. Vollmer, how exactly do you eliminate or sidestep insurance companies or government healthcare systems? Since this is the foundation for patient care and research funding, how can doctors, patients, and families lobby insurance companies for freedom to medicate?
So I think it's just that, is that it comes from patients and families dealing with MS saying that this is unfair, it's bad medicine, it's bad practice. We also need to talk to our lawmakers about the behind closed door deals that are made between drug companies and insurance companies where that causes insurance companies to prefer a certain drug, not because it's medically the best, but because they're getting a discount on it. We also need to have those of you that have been on a couple of different therapies and have experienced what natalizumab can do, or what rituximab can do, or what fingolimod can do. We need you to make it clear to these insurance companies these drugs are not the same. The insurance companies are treating them as though all these drugs are the same, and therefore they want to just use the cheapest one. But we need you to tell your stories, to advocate. And I would argue very strongly that the group that you could look at, the two groups you could look at to see major progress in this area is the HIV community and the cancer community. There are laws that were passed by legislatures as a result of advocacy from families and individuals dealing with those diseases that give those folks a lot of protections and a lot of other options. We need to do the same thing. And I think the Recommended MS Center, we probably need to gear up and be more effective at advocacy, at helping making you visible and your experience with these drugs visible to those people that make these decisions.
How do you sign up for the Healthy Brain Control Group?
In the hallway out here, there's the Recommended MS Center team off to the left, and there's several of my research colleagues there that can give you information and tell you how to contact us and move forward there.
I'll add real quick to you as well that we're looking for patients who have been on treatment for more than 2 years, especially Copaxone and Gilenya for the same studies. Thanks.
Are we out of time? No? Okay. Could we, to anyone, can we discuss the hormonal, if there any hormonal impact of MS? Does menopause make MS worse?
That's all you.
Thank you for asking me that question. There's a potentially profound role of hormones, especially in women, as it relates to multiple sclerosis. We have completed one trial with using estriol in comparison to placebo as an add-on agent in women with MS. And although it's not published yet, it's been reported multiple times, that at 1 year there was a reduction in relapse rate as well as an improvement in less new MRI scan lesions, as well as an improvement in cognitive function in patients who took the estriol. In addition, we're now doing a follow-up study looking at estriol just focusing on cognitive improvement. There are a number of aspects of MS that lead to the logic for why hormones are relevant. Very important one being pregnancy. We know that pregnancy is somewhat protective. Perhaps breastfeeding is also somewhat protective. There's never been a large study that I'm aware of that would suggest that menopause has a big role one way or the other. I think what we've been discussing all morning that is perhaps related to that is this age plays a role in how MS impacts on people and how it affects their function. Whether or not hormones also play a role with the removal of the hormones, I think remains to be seen. I don't think anyone's really identified a large role, though, for menopause.
Okay. How do you determine the difference between normal brain aging and MS-specific symptoms?
So as we were discussing this morning, MRIs allow us to have a quantitative way to measure the amount of brain in individuals with MS. There are certain types of MRI, and we're using one of those, which is called a free surfer, that is allowing us to not only get a sense of the total brain volume, but also to quantify different areas of the cortex of the brain, the neocortical volumes, to do segmentations between different lobes. That gives you an idea whether this is just a generalized brain atrophy as part of aging versus something pathological that is driven by MS that will hit specific areas of the brain that are different to just the normal aging process. So I guess the answer is MRI is probably one of the easiest tools to use to address whether the brain atrophy rate is a pathological process from the underlying disease course or is just a process that is reflective of normal aging.